How has all this been going for you?
It's been going. It was a little scary at first, and Mesa County is different than everyone else, apparently.
Yes. It's like the Wild West out here in general, but I think that's our whole country is running that way right now. So it's like a microcosm of our own country. So
Yeah.
in that way.
Can I first get you to state your name and spell it for us?
So yes, I am Dr. Gayle Frazzetta, and I'm a family practice physician here in Montrose, Colorado.
What did your average day look like pre-pandemic?
So my average day was probably 8 to 4, probably 3 wellness exams during the day, a couple of work comp cases during the day. I actually specialize in hormone therapy and osteoporosis, so I do a fair amount of consults on that as well. So that probably is about 40% of my practice. So that would be both face-to-face visits essentially, and then a procedure, putting hormone pellets in. So I'd probably have a couple of those a day, procedurally.
Wow. And what's your typical day transition to now that when everything closed? What was your day like? And now it's becoming, right, as things start to open up again.
Right. So basically telehealth. If you would have asked me a year ago if I would have considered telehealth, and people did, because I have folks traveling over an hour to come get a consult. I was like, no, I want to see my patients, face to face, kind of in my office, and have that kind of conversation. And so it had to go to telehealth within 24 hours, essentially. And so it has worked remarkably well, better than I anticipated, actually. The connectivity is an issue for people who live in more remote areas. And then I also find everybody's on the internet now. So sometimes it's a challenge just being able to do a full discussion, because halfway through the audio may go, or there's a delay, and it makes it challenging sometimes in that way. And on occasion, I've had to just go to a phone call because the connectivity is just not possible for that person, because of internet issues.
Yeah.
But in general, I almost feel like the old country doc reinvented and going to people's homes.
Yeah.
It has been interesting that way. And I have, a couple of patients who are artists who were thrilled to, give me a tour of their art around their house. So it was kind of even learning a little more about my patients than I already knew,
Yeah.
And just they're so proud and happy to be able to see that and share that with me. So in that sense, some things have been really great. It also gives me a sense sometimes of the environment that people live in, so another aspect of primary care, to see where they actually live, of their environment.
Well, that's awesome that this has given you an opportunity to try telehealth, and that you're finding it to not be as, bad. I mean,
the efficiency of it also, somehow, like the visits are longer when people are physically in my office. Just the process of, my staff greeting them, and vitals, and the chit chat, and then all of it. So it's a shorter visit, but it's not that it's a lesser visit. It's a more efficient visit, if you will.
Mm-hmm.
And I find, I throughout this have still had patients physically come to the office, but only where it was absolutely necessary. So I mentioned that procedure that I do if people needed a skin biopsy, for instance, or a joint injection, or someone had a really bad rash that you couldn't really get a sense well enough on that video. So, and in that case, or blood draws, but what we've done though is there's only ever one patient in the office at any given point in time. So nobody sitting in the waiting room waiting. They knock on the door. My staff meets at the door, making sure they have a gloves and masks. And then, it's the efficiency of just bringing right back to the room, getting vitals. So minimal exposure for everybody. Everybody's got masks and gloves and all of that. Some folks even just pull up in the parking lot and my staff goes out to meet them if they need to hand a urine sample off or, any number of things. But if they could stay in their car, they actually will take care of whatever they can do in their car, actually. So in that respect, it's been a lot more sort of coordinating and scheduling, to be sure, and work comp, having to do, I do some work comp as well, and that has obviously gone to online, and it's challenging also because people don't have a job to go back to. So in many instances in work comp, you might say, okay, well, you're 80% better, or you think you're better. We're going to send you back to your regular job position and see how it goes to make sure that you're okay before I close your case. You really can't do that now. Not only is there no job to go to, but it's not even like they can go to the rec center and do a self-directed program. So for many, it's helping them figure out what they can do at home with whatever they have available at home to try to get them better.
Wow.
Actually. So that's been a change also.
How many of these, so let's say this goes away tomorrow, right? All of a sudden, poof, a miracle. What of these practices will you retain?
So I've actually talked to my staff about this already because, just wearing a mask in general, you in the past we've done it. Like if you're sick, we always had masks out on my counter. I think culturally, we just haven't been doing that. If you look at Asian cultures, they always wear a mask, especially if they're sick, as a courtesy to your mankind, essentially. And I'm hopeful that we will be more diligent about doing that. Also, immediately coming and going in the office, you need either to wash your hands or hand sanitizer, and I have wall-mounted units, but getting in the habit of reminding patients that they, there it is right next to the counter, please, but, do the hand sanitizer. So I think that aspect, like mask and, wash your hands, sounds simple. I'm hopeful that will carry forward, because whether it's flu or strep or any other virus, you don't want to be spreading it, because that's all of this stuff spreads, and this virus pandemic is not unique at all. I mean, it was a predictable event. We just
chose not to think about it.
Yeah, we just got to pull our pants down, so to speak. So yeah, it's to look back. I enjoy like TED Talks and whatnot, and you can go back 5 years ago. There's TED Talks just talking specifically that this was coming. And there was no funding to continue to develop a vaccine and develop the tests and all of that. So this is what we got.
Do you think you'll continue with telehealth?
I will continue with telehealth, actually. That aspect has been good, with the assumption that they will have reasonable hoops for me to jump through. In the future, I will do telehealth. For me, I have been not a technology fan, in the sense that I actually still have paper charts in my office. I say I'm going down with the paper ship. So you know, that's another part of telehealth. I thought, would I ever be doing telehealth? And here I am. So I'm still on paper charts, and yeah, they've yet to prove that it improves patient care and patient outcomes using EHRs, essentially.
Mhm.
Tell you what, I have a smile on my face most days working, whereas a lot of physicians are actually jumping ship, partly because of the technology required of them now.
Mhm.
So in any case, the telehealth, it's an easy add-on because it's doesn't, I can still use my regular charting and whatnot. It doesn't force me to get a whole EHR.
Have you had to reduce any staff hours?
Mm-hmm. Yeah, I had to do that. I have a nurse practitioner who works with me. So so she went down by 50% basically. And, you know, my own hours, there were fewer patients, so that got cut down. And then staff. Fortunately, I have staff that are not necessarily breadwinners for their families. So for them, it wasn't a big challenge. And so the staff that I have who are really relying on that paycheck, everybody kind of worked together to make sure they got the hours that they needed to get. The other change that was pretty significant was just bone density studies, because that, as I mentioned, that was my other specialty, was osteoporosis. So I do bone density screening in Montrose. I actually have the only DEXA here in town. So that all got put on hold. We did critical ones, folks who were needing it, say, to start their cancer treatment or whatnot. So extremely limited for those. And we've just started to do those again, actually. So those all went on hold. So the techs that I have that would normally do that, you know, didn't work at all during that time also.
Mm-hmm. Here at this list of questions. How can you talk about COVID in your community, in Montrose, and how many cases and?
Yeah, sure. And I feel like for me, it's been almost living a parallel life, because my sister is a nurse practitioner in New York at one of the really terribly hit hospitals on the South Shore of Long Island. So, I have been seeing her go through some of the most challenging times in her career working in that hospital. So anyone here in this community who is like, oh, it's a hoax, I'm like, it is absolutely not a hoax. And I have very little patience for the folks who tell me that, actually. You know, in one single shift, my sister had to pronounce 5 people in one single shift. Like most people in their careers don't pronounce 5 people. And in one shift, she had to do that. And imagine, you know, on her own cell phone that's in a plastic bag, Skyping their family so they could say goodbye to their loved ones. Like how hard that is over and over that you have to do that. So, so my view of it is a bit different than, you know, we haven't been overwhelmed here in Montrose, and we had the luxury of seeing what New York was going through and then being well prepared for it. So I think actually the Western Slope has done a good job at pooling resources and working together. You know, even between Montrose and St. Mary's, deciding like who's taking the Gunnison COVID patients, because early on they had the beginning, it was Gunnison had a handful of cases. So I thought it was really great that the hospital systems were working together in terms of, you know, equity and who's got ventilator capacity and whatnot. Within my own practice, I early on had someone who worked at the airport who was positive in the beginning of March. And then I had another person who got it from one of the local nursing homes. And unfortunately, 4 or 5 days later, her husband, both of whom are my patients, her husband also contracted it, and he ultimately died from it. And then I have another patient whose husband died as well. So, and I probably have 4 other cases of people who are not hospitalized but have gotten it. So I'm a small practice, and that is what I have carried with in my own practice. So our hospital system hasn't been overwhelmed like it has been in New York, but we've had 10 deaths here in Montrose, or in Montrose County, I should say. And I believe there's a little over 100 cases now. So that's a 10% death rate, which is not a great statistic. So the other really thing I find challenging is the people who are, choosing to do their personal rights protest on the corner. I actually, by chance, ran across that little protest, innocently going to the farmer's market. So I actually purposely went by there to see if I would know anybody, specifically if there were any of my patients there, because I thought they're going to be in a lot of hot water if I have patients there. Fortunately, there were no patients of mine there, but someone I considered a friend was actually there. So that presented itself as a pretty challenging situation. So yeah, I went and spoke my mind at that protest. I asked them all to not go to the ER when they got sick and to stay home, right? Be the brave citizens they think they are. So, it's easy to do something like that when you have very little risk, right? Mm-hmm. Also, I also found it very disheartening though, because imagine you're that person whose loved one died.
Yeah.
Driving by that. How awful that would be. So
what about their rights?
Right. I think rights, you don't have the right to put people at risk. Nope. You can drink in this country, you can drive in this country, but you can't drink and drive in this country. Not that anyone would care if you drove yourself off a cliff, but because you might injure someone else. Yeah. So it's, we have laws like that already in place restricting our personal freedom. So this is no different than that, as I see it. So, it's I think politically, it's become somewhat political, which is very unfortunate. But I think that message was sent kind of on a national level right out of the gate. So that was the initial way that this was handled. So, that continues to trickle down because that's the initial message that everybody got. Mm-hmm. So that was, I think, a very grave mistake to make it politics, essentially.
And I see that message being, it's one of the consistent messages, right? We get so many different, today this is what, this is the latest news and that's the latest news and it's changing and that one hasn't changed.
We have some of the leading experts on the planet in terms of disease management. We have the CDC. They are experts, helped manage the Ebola issue and SARS and MERS. And we have people that have trained their whole lives to manage situations like this that were essentially silenced. Yeah. And so that is really a sad state of affairs when that's how this kind of situation gets handled. Because that coronavirus doesn't care what political party you're in, right? Yeah. Non-discriminatory.
It is non-discriminatory. I've heard, can you speak to the social determinants of health at all? Can you talk about how, I hear people say, oh, this is the great equalizer. It doesn't care who you are or what you are. Everyone's at risk, but we do see, that it's disproportionately affecting certain groups in our country. Can you speak to that at all?
Sure. So, I mean, in general, medicine only contributes roughly 20% to people's healthcare outcomes. The other 80% are social determinants. Do you have access to clean water, decent food, a roof over your head, good social support systems? So really, if you think about what I do, that only impacts people's lives 80% on a good day. So when you look at those groups of people who are hit in such a disproportionate way, yes, their level of poverty absolutely has an impact on this, and quite honestly, where they're receiving health care probably influences that as well. And even just, if they're starting out of the gate behind, meaning if nutritionally they're already void of many of the critical things that people need to fight infection, whether it's vitamin D or adequate protein stores or vitamin C, they are already going to be starting out behind the eight ball, if you will, and then hit and be in areas where there's so many people potentially living so close together that they don't have an option to social distance. They may be in an apartment complex where you really can't realistically socially distance, and so it will spread through that quite quickly. So those social determinant factors, I think, are relevant. The other thing is, vitamin D is being pretty clearly linked right now to it as well. Vitamin D actually isn't technically even a vitamin. It's a prohormone. It's kind of mislabeled when it was initially discovered, but it has a critical role in many different functions of our body, including our immune functioning. So in general, people who are darker skinned are at higher risk for being low in vitamin D because your skin doesn't make it as readily, actually. So a higher proportion of Blacks and Hispanics will have lower vitamin D's levels across the board. So that also very clearly has put them at higher risk for this infection and a poorer outcome, actually.
Wow, I had no idea. You weren't you involved with the schools when they do the sex ed at the end of the year, and so there wasn't any of that, or was there?
No. Well, interestingly, our school had just I think was the end of last school year. Began using a group out of Grand Junction, actually, that did a 4-day program for them. It was initially geared towards HIV prevention, and then they expanded that program to be a 4-day program, where they then covered consent and contraception and HIV and whatnot. So that is who in this past school year who's been doing it. So yeah, for 20 years, and then they transitioned to that, and it actually worked well. They used, we had a box of contraception stuff and how to put on a condom. Actually, like physically, everybody gets a condom and gets to put it on a penile model. But they used all of that stuff, and actually, if you think that 4 days is a much better amount of time, we only used to get in and get 1 day. So I think it's a good thing that they've moved to that. I've actually been working a little bit peripherally with Delta and the person trying to get Delta up to speed, because Delta's been behind for a long time. Yes. So, but litigation actually puts your feet to the fire and gets things moving. I don't know if you're aware of that.
No.
Yeah, I think it must be 4 years now. There was it was a valedictorian and maybe a couple other students that went to the administration and said, we want something more than the speaker that they paid. The speaker actually is like a nationally known sex ed speaker, but like featured on John Oliver. If you know who John Oliver is.
I don't.
Oh, he's a talk show host. In any case, she's one of the speakers that essentially uses shame to shame girls into not having sex. So essentially during her talk, she'll say like, oh, if you're a girl and you choose to have sex before marriage, you're like a used pair of sneakers or an old chewed piece of gum. And that kind of talk. And so that Delta paid, I think, $1,700 a pop to pay her to come and do that. So a few students went to the administration and said, that's fine, you have that, but we want something else, more scientific, neutral, not shame-based. And they basically blackballed her. They didn't allow her to give a graduation speech. They didn't send out her college applications to get scholarships. They lowered some of her grades. So essentially, they got sued. So I haven't heard where that is currently, but because they were getting sued, obviously it doesn't look so good in court if you're still doing the same shame-based sex ed that you've been doing. So they have made some progress now at moving forward with that. So
that's good to hear.
Right. Yeah, they're not all the way there yet, but they're at least moving in the right direction.
Do you ever precept students, medical students? How will this experience influence you in the future as an educator, as a healthcare provider educator, or an educator of future healthcare providers?
A mouthful. Well, I think it's just a level of preparedness, that we need to be on a national level. So, we don't have a lot of control as individuals other than how we run our practices and the examples we choose to set. So I think like even now it's important for healthcare providers, also my staff. Like imagine some of my patients, if my staff was out without a mask on, how that would look. So, for me, when I run into people who I know work in restaurants, or I know this person's a bartender, I know he's out of work. And for him walking around without a mask on at Home Depot, it's just foolhardy. Like he's suffering like greatly from that in the job position that he holds. And despite that, he's still choosing to not wear a mask out at Home Depot. So
I'm not sure they see the connection there.
Yeah, like how sorry can I feel for you if you can't even bother wearing a mask?
Yeah.
So, I think it's setting an example. You can't ask people to do things that you yourself are not going to do. And I really, especially like even thinking of Mike Pence not wearing a mask at the Mayo Clinic, I actually I wish the Mayo Clinic,
said no, thank you, Mike Pence.
I wish they stuck to it and insisted on it, because that it's just unfortunately, I'm sure the Mayo Clinic gets government funding, at some point. So of course, therefore, do you really say no to the Vice President of the United States because you get funding from the government and you don't want to compromise that? And I think that's unfortunately now where a lot of medicine has gone, is you're always having to think of where that funding source is coming from, and do I want to annoy whoever might be at the end of that funding source, even though it might be a different government agency. Of course, there's communication along all of those lines.
Mm-hmm.
Yeah. So the other thing you mentioned, just to go back to the Hispanic and Black communities that are affected, we talked about that. I think the other disparity out there is a gender disparity, because there's, I believe, more men being affected than women.
Mm-hmm.
So I think for me, even before this, that has been such a big disparity in healthcare, is gender bias.
Mm-hmm.
But it doesn't serve men or women if you don't look into why there are gender differences. For instance, like if we do say that there's more males than females impacted, we should pause and say, why is that? Is it because they have different levels of hormones, or different stress hormones, or different whatever it may be? But we don't really think in those terms in medicine. For instance, many studies, and I'll just choose cholesterol lowering medicines, the majority of the people in those studies, at least 80% of them will be men, 20% women. They don't ever separate out how do the men respond and how do the women respond. They pool all of it together specifically really so they can get more customers. But there are clear gender differences between response to statin drugs, for instance. Just to use one example. The only drug, or the first drug that I'm aware of that came out with gender dosing was Zolpidem, which is a sleeping pill. So that was 10 years after it's already on the market, they changed the dosing from, for women versus men. And that's 10 years later. So we really should, to benefit both men and women, look at how they respond to different treatments or how they respond differently to the same treatment, essentially.
Mm-hmm.
Well, that's the other part of this virus, is figuring out why men are more affected than women.
Yeah. So strange, and initially we thought this was not going to impact young people either, but we're finding out, now that it's here, that young people can be just as affected.
So you listen to that. Imagine in the hospital my sister works at one point, I think they had a 7-year-old die from COVID. That same kid's other siblings were in the ICU. So it was a family, essentially. But the 7-year-old died. About 2 weeks ago, they had a 17-year-old die. And it was not ever an uncommon thing for her to be talking about. There's usually men in their 30s, like 35, 38, that died. So, to think, it's just old people, and that is so absolutely not the case.
Yeah.
So it may happen less commonly, but it absolutely still happens. And they did not necessarily have conditions that predispose them to that. And then the other thing in my practice, I mentioned those people locally, but then I have patients, one I just saw recently, her nephew at 51 died from it. And another person in Florida, their 35-year-old brother-in-law died of it. So, it's there, and it touches lives quite a bit because, whether it's family, friends, et cetera. And then that or my personal rights little protest thing, they wanted to immediately quote, flu, like not, at that point it was fewer deaths than the flu. And I'm like, okay, that's fine to say, but you realize we're only at this 6 weeks.
Yeah. This has not been around a whole year.
Right. We haven't had, just give it time. The other thing is to even say, well, this is the same number of deaths we have in car accidents. All of those car accidents don't happen in 20 days.
Yeah.
6 weeks, whatever. They don't all happen because it's overwhelming the healthcare system in that context. So people don't really understand that aspect of it either. And then there's some professions that, like anesthesia is at risk because they have to intubate patients, right? So, and then really maxillofacial surgeons, dentists, if you're thinking about it, you're working in someone's mouth and airway for sometimes hours at a time. So they're at very high risk. So that's going to be another whole ball of wax for them managing that day in and day out in their practice.
I hadn't even thought of that. Why my daughter's dental appointment keeps getting pushed out. And
yeah,
I can totally understand not wanting to do that right now.
Yeah, and then our testing is not reliable enough. Here we are in May, and you can't accept a 25% false negative rate. And
I heard another doctor tell me that too, and I hadn't realized that that's how large it was. 25%
for some of the tests. But I could go online, order through whatever company some tests and run in my office. I have no idea how accurate it is at all. then are you going to base clinical decisions on that? So it's really challenging. That's another extreme shortfall of our government, was their just inability to coordinate that sooner. Our first case was January 19th, and I think by the end of February, we had tested 475 people in the entire US by the end of February. Like that's just obscene how few of tests that actually is.
How is testing in your community in Montrose?
So, we've had tests, and you do have the ability to get testing here, and we've had variations in turnaround time. Like, we did in fact get a machine that has a 45-minute turnaround time. The very first one that they did, they tested that patient, it came up negative, but then they also sent a sample to the state, and the states came up positive. So, right out of the gate, you're like, well, how accurate is this testing? It'd be great to have a 45-minute turnaround.
If it works.
If it works, right? So now there is a saliva test that actually is coming online that's supposed to be, it has what appears to be good data behind it. So a saliva test, I believe the turnaround time now, because of the volume of people after that, I think it's 3 days now, but it allows the patient themselves to collect that. So you don't need to put people at risk collecting the nasal sample.
Mm-hmm.
So you could basically walk out to someone's car, hand them that vial, or people could pick it up, take it home, fill it up with saliva, and send it in. So that saves a lot of personal protection equipment with that test. So that, I think if we're not already doing it, it will be in the next day or two that we'll have that going. So that will help certainly with that. But we are just so behind as a country in this testing, and then antibody testing. We don't even understand, even if you have antibodies, whether that is fully protective or not, or how to interpret that at this moment. So
yeah, the thought that just because you have had coronavirus doesn't mean that you couldn't contract it again later.
And that's the
scary.
Well, that's the unknown, right? Because in general, you would expect that you'd have a less severe case and a shorter case of it. That's true, but it's still too new to even know how to interpret that.
Yeah, and what damage it's going to do to your body the first time versus perhaps the second.
Yeah, and all of those. There's a lot of unknowns.
What are you doing for you to take care of yourself? This is a lot of stress. This is,
yeah, but it's
and frustration.
My life hasn't changed a lot. My college-age children were home my college-age young adults were home for a month. So, that was a great opportunity to spend time with them, and certainly a challenge for them in terms of trying to keep up with their college work. One of my sons actually graduating from CU, so really kind of just unfortunate that he's missing all that. It's kind of, you work that hard for that long, and it kind of is just this little fizzle at the end. So,
mm-hmm.
But it's just the way things roll. So you make the most of it. So that aspect changed for me in terms of my home life, because my office, we transitioned to telehealth right away. My day didn't look a whole lot different than it did initially. So it didn't feel that different for me. My husband is an orthopedic surgeon, however, hasn't been in the OR. They're just starting up again, doing elective cases, but that has been a change, certainly. And I think just as far as what I do to take care of myself, it's all the usual stuff that really hasn't changed. Because I usually didn't go to a health club necessarily, so I didn't have a giant impact from that. Because I definitely have some people that's the only place out, and it's been a challenge for them. But for me, it hasn't changed a lot.
Is there anything else you'd like to talk about or that we didn't touch on that you'd want to share?
No, I guess just, my concerns now moving forward about, how we all choose to remember and allow this to change the things that needs to change, as opposed to we just sort of like go back into that same pattern with blinders on and don't reflect back on this. That would be a mistake, because it has brought out so many flaws in our healthcare system. And I think this is a big opportunity to correct some of those healthcare flaws. And, I just think even like in my sister's case, so many of her coworkers are there in some of the most high-risk situations, and they don't have health insurance. The EMT people come and bring patients in, they don't have health insurance. So it's like, how is it possible that these people can not have health insurance? But on the same token, why doesn't everybody at least have some basic health insurance?
Yeah.
And for insurance companies to they're very interested in just keeping things the way it was, because United Health, I think, made $14 billion last year. So it was amusing to me to notice a government website is run by United Healthcare. Like, I guess with $14 billion in profit, you're going to step up and help the government run that system, right?
Okay.
And then even insulin prices. I laughed. I got that, they were going to give people with diabetes a break, and they were only going to charge them a $35 copay per month for their insulin. Well, it costs between $3 and $4 for them to manufacture and get that insulin out the door. So they're still making a very big profit in the muck of this on insulin. Something people can't live without. So I hope if nothing else, that because of those glaring deficiencies in our healthcare system, that something changes.
God, I hope so too. I really enjoyed talking to you. This was a great conversation. Thank you so much.
Well, it's nice to meet you in person, Nicole.
You too.